Hi guys, let's read about management of cardiogenic pulmonary edema. So initial management is sit the patient upright, give oxygen if saturation is less than 90%, double IV lines, and monitor ECG, treat any arrhythmias if they are, diurese the patient by giving furosemide 40 to 80 milligram IV. If patient is already on 40 milligram oral dose, then give 80 milligram IV initially. Larger doses if patient is having chronic kidney disease are already taking diuretics, which I mentioned as well. So nitrates, if systolic BP is more than 90, give nitrates. GTN spray 2 puff sublingual or 2 tablets of 0.3 milligram sublingual. Intravenous infusion of GTN 50 milligram and 50 ml of normal saline 2 to 10 milligram per hour. Titrate to systolic BP of more than 90. Look for the cause of cardiogenic pulmonary edema. Take complete history, examine the patient and investigations. Treat the cause. If it is SES, go for the treatment of SES. Hypertensive emergency, control the blood pressure. If there is no improvement, give further dose of IV furosemide 40 to 80 milligram. Increase the nitrate infusion, keeping systolic BP of less than 90 millimeter of mercury. Consider CPAP or BiPAP if type 2 respiratory failure, then BiPAP, otherwise CPAP. It improves ventilation by recruiting alveoli. Consider alternate diagnosis, for example, pulmonary embolism, pneumonia, aortic dissection if patient is still not improving. If systolic BP is less than 90 mm of Hg, then treat as cardiogenic shock. About the dosing of loop diuretics. If diuretic naive, the usual initial IV dose of furosemide is 40 to 80 milligram, depending on the 0.5 to 2 milligram per kg dose. If taking regular oral diuretics up to 2 to 3 times the previously ineffective oral dose may be needed. If in CKD, high doses of diuretics are needed for further tubulary delivery to be sufficient to cause diuresis 2 to 5 times depending on the CKD stage. Furosemide has a short duration of action, except in CKD and post-diuretic sodium retention can occur. Although there is no measurable effect in all-cause mortality, length of hospital stay or electrolyte disturbance with bolus versus continuous infusion. A continuous infusion may be superior in initial measured diuretic effect and reduction in beta-nitriuretic peptide. So if your patient is not improved with one dose or two doses, then an infusion is also suggestive if patient is clinically unstable. So that is about the management of cardiogenic pulmonary edema. If you have any question, do not hesitate to ask in the comment section. I am reading this from Oxford Handbook.